Dr. Prashant Dixit. He is a fellow in neonatology, IIP, pediatrics and research, neonatal intensivist, and scientific director at our newborn center along with Dr. Shweta Chau. Welcome you, sir.
Good afternoon, friends and colleagues. I thank the Perinatology team, as Sir has said, a new term, for the obstetric and the pediatric team of Thane. So we'll start our talk with two pearls of wisdom, two pieces of advice for married men. Never laugh at your wife's choices, you are one of them. And never be proud of your choices, your wife is one of them. There are some more facts of life. The position of a husband is like a split AC. No matter how loud he is outside, but inside the house, he is designed to remain silent, cool and controlled by remote. So with this we come to today's topic, husband-wife relationship in modern India. So today's talk is first golden hour. We will be talking on the first golden hour of the newborn. Birth is nature's magic, through which a water animal becomes land animal. And everything subsequent to that is maintaining that balance of life. Neonatology is doing that tightrope walking. Subsequent to the delivery. So good perinatal care has seen the neonatal mortality rate drop to almost half, from 57 to 28 in the last 25 years. Still India contributes to the highest number of births in the world, almost 20%, and the highest number of deaths, neonatal deaths in the world, almost 30%. The India Newborn Action Plan 2014 has envisaged a neonatal mortality rate of less than 10 by the year 2030. So we have 13, 14, 15 years more to achieve a neonatal mortality rate of less than 10, single digit mortality rate. A skilled birth attendance and essential newborn care is the key to achieving this. 450 newborns die every hour. This article was published in the Lancet in 2005, and most of them are mainly from the preventable causes. A good newborn care given in the first 60 minutes of life can help us prevent these deaths. So what are we going to see today? The delivery room preparation mainly, in the use of bag and mask, giving a warm welcome to the newborn, how do we transport the newborn to the higher center or appropriate transfer of the newborn, the dilemma between oxygen and room air, use of delivery room CPAP for the baby having respiratory distress after birth, ensure using surfactant, using the ensure technique, and sugar monitoring or dextrose post delivery, vitamin K prophylaxis, and also we will be looking at identifying some red flag signs in the newborn after birth. Delivery room preparation mainly is regarding three things: a good environment or a warm newborn corner, a skilled birth attendant, or as we say, a person skilled in resuscitating a newborn, and the equipment to be kept ready. We have given a folder in which there is a laminated sheet which contains the list of equipments to be kept ready, and also the IIP algorithm for newborn resuscitation. This can be fixed in the delivery room near the warmer which we use for the newborn resuscitation, or just near the OT where the delivery is going to take place. The equipment should be kept ready at all times. It's easy to remember what all we need to maintain for the newborn resuscitation: the temperature, the airway, the breathing, circulation, and dextrose. So the equipments are appropriately listed in the pamphlet. The equipment should be checked whether it is functioning or not prior to every delivery. So we, especially the AMBU bag, which is likely to malfunction or not work when it is most needed. There is IIT is conducting a lot of courses in get trained in NSSK or basic NRP, Dr. Anand may be holding a few sessions here. So they will help us become trained in NRP, getting skills in NRP. Also the staff can be encouraged to get trained in the same. This is the algorithm which is attached in the folder. So stepwise we need to follow the algorithm after birth. As we see, the least used techniques of resuscitation, the endotracheal intubation, chest compression and drugs. These are at the bottom of the pyramid. 99% of the babies do not need this. 99% of the babies will be happy with just basic care, initial steps of resuscitation and positive pressure ventilation. Only 1% babies would need resuscitation beyond bag and mask ventilation. So the key to this is an appropriate size of the mask, shape of the mask and application of the mask so that the seal of the mask on the mouth is proper. Position of the attendant with regards to the baby is important while giving bag and mask ventilation. In terms of that golden minute where we resuscitate the newborn or where we ensure that the newborn is breathing, the ventilation of the baby's lungs is the most crucial step, and an increase in heart rate is the most sensitive indicator of a successful response to resuscitation. So these are the two things we need to remember, that we need to make the baby breathe, and if the heart rate is improving, the baby will definitely show improvement. We were given a warm welcome when we came to Thane, the weather as well as the organizers. So the same way we should give a warm welcome to the babies in this world. Babies are usually homeothermic at birth. Their temperature is almost 0.5 degrees higher than the mother's temperature. And subsequent to birth, they have non-shivering thermogenesis through which they generate heat. So the brown fat which the babies have, it is metabolized to produce heat, and it is then gradually transferred through blood circulation to the entire body. However, these babies get hypothermic mainly due to lack of attention by the healthcare providers, which is us. And that is one of the most important causes of or contributory causes to the death in these newborns. In the first 10 to 20 minutes, a newborn may lose up to 2 to 4 degrees centigrade of temperature. Newborns are wet, so they lose heat and get cold. They may lose heat through conduction, convection, evaporation and radiation, which we learned somewhere in 5th or 6th standard in physics. All these methods work when the newborn is born. A thermoneutral environment is very essential to maintain that temperature. A normal axillary temperature which we target is 36.5 to 37.5 degrees centigrade. Clinically, in the labor room, we can see 36.5 to 37.5 degrees centigrade, the baby will have warm and pink feet and a warm abdomen. A baby with cold stress, so 36 to 36.5 degrees centigrade, the feet will be cold though the trunk is still warm. A baby having temperature less than 32 or less than 36 rather, or suffering from moderate hypothermia or severe hypothermia, both the feet and the trunk will be cold to touch. So clinically this is how we can judge the baby's condition and provide warmth or provide treatment accordingly. The warm chain needs to be maintained for a baby in the first 1 hour. So a warm delivery room is essential. It has to be kept ready. Warm resuscitation, in case the baby requires help, requires resuscitation after delivery, a warm resuscitation should be provided. Dry the baby as early as possible and change the linen after drying. It is not only drying but changing the linen also, which is important. If the baby does not require resuscitation, then of course skin to skin contact with the mother is to be provided. Postpone bathing and weighing. So these two things which are likely to give a hypothermic stress to the baby are to be postponed till the baby is stable. Head cap and clothing can be used if resuscitation is not required to keep the baby warm. And in case the baby requires transport, in case of sick newborns or preterm newborns requiring transport, a warm transport method is to be provided. We try to maintain this warm chain for the baby post-delivery. The temperature maintenance during transport is supposedly the weakest link. There have been studies regarding that, and the most important thing is to stabilize the temperature prior to transfer. Record the temperature, and it's not only record the temperature, if the temperature is low, take steps to rectify it before transporting the baby. Cover the head and wrap the baby. Postpone cleaning and weighing the baby. The baby may be weighed in the NICU and then the weight can be telephonically informed.
we usually have the tendency, no, baby is going out of the obstetric or the labor room, please weigh the baby. We need to tell the relatives. That can be done a little later once the baby is stable. Use transport incubators or warm incubators for transport, and carry baby to the close to the chest of the relatives in case the transport incubator is not available. For ELBWs and babies who are extreme preterm, early preterm babies, we can use polyethylene wraps also, which are very helpful. Why we are trying to avoid this hypothermia? Basically, hypothermia causes acidosis, which leads to pulmonary vasoconstriction, further leading to pulmonary hypertension, which causes right to left shunt in the newborn. This right to left shunt actually worsens the hypoxemia, further leading to tissue hypoxia, which promotes anaerobic metabolism and actually worsens the acidosis. So we get trapped in a vicious cycle because of this initial hypothermia. In the long-term effects of hypothermia, it may cause worsening of respiratory distress syndrome, it may cause metabolic derangements, interventricular hemorrhage, derangements of coagulopathies, increased risk of BPD, and further leading to increased mortality in the newborn. A audit of admission temperature at NICU was carried, and if you see, incidence of hypothermia was more in babies who were 33 to 34 weeks and 35 weekers. Usually these are the babies who are neglected. The babies who are less than 28 weeks, 29 to 32 weeks, we take extra care, extra precaution, they are very small. So their incidence was 35 to 45%, whereas it was much higher in little bigger babies, those 1.8 to 2 kg babies, typical 32, 34 weeker, 35 weeker, who has cried immediately and then requires transfer, so then everyone leaves it to the transfer team till they come and actually shift the baby. Or at times even the ambulance is not used, they are sent in the auto or something like that. So each 1 degree decrease in the baby's axillary temperature will increase the mortality by 75%. I still remember during our fellowship, there was a 1.1 kg baby, and who came in and baby cried immediately, was breathing well, X-ray was good, surfactant was not required, and next day we presented rounds, we were very proud and we said surfactant is not required, X-ray is good, maybe antenatal steroids was given as recommended by Dr. Anand. And sir saw the sheets and he said, Suryavanshi sir, he said, admission temperature was very low, poor outcome, poor outcome. I said, what is this? Should be good. Surfactant bhi nahi laga tha, everything was fine. And at around 36 hours, the baby had grade 3 IVH. So then we could correlate that hypothermia has resulted in a long-term increase in mortality. So it is not only giving antenatal corticosteroids, giving Maxulf, and taking other care. Maintaining the temperature post-delivery is also one of the most crucial steps. It can worsen the survival and the morbidity in a different ways, in a wide variety of ways. So Vaughan and HELP trials have also recommended use of plastic bags, which help in reducing hypothermia at 1 hour of life. Plastic wraps are especially effective in reducing hypothermia in less than 29 weekers. So 1 kg, 900 gram, 800 grams. ELBWs, we can definitely use plastic wraps. These plastic bags are food grade plastic bags which can be used to transfer the baby after delivery. We need not dry the baby once the baby is born. We need not dry the baby or change the linen. We can directly receive the baby in these plastic bags. The neck can be kept out, the head can be covered with a cap, and the respiratory support, whatever is required, can be provided. In case the plastic bags are not available, we can use the polyethylene drape, which is commonly available in the operation theatres or labor room. The surgical polyethylene, that green wrap, that can be used to wrap the baby like we use a cloth. And see, the head is also covered and the oxygen support is provided to this baby. So this can be used for transfer. The best transport, we all will agree, is in utero transport. That is the best mode of transport. So we can never have the best transfer system in us. We can always aim to be the second best. So what we need to do is develop a skilled transport team, which designated roles for each members. So the driver is there, the helper is there, attendant, the nurse is there, the doctors are there. Appropriate equipments and the vehicle should be customized to transport newborns. It should not be an adult ambulance which is also used to carry newborns with full blast AC and music and all those things. It should be a designated newborn transport vehicle. Briefing before the transfer. So we need to tell the staff what we are going to expect there. If there is twins, we just chalo ambulance call it, leave. No, we should tell them we are expecting twins, so they carry everything accordingly. Or we are expecting a less than 1 kg baby, a extreme preterm baby, LBW baby. So things are then carried accordingly. And debriefing after getting the baby. Once you stabilize the baby, call the team, call the ambulance team, and also tell them what all happened, what all was good, and what all may be needed to improve. So while transporting, we need to take care of the temperature, airway, breathing, circulation, and dextrose, the TABCD of emergency medicine, and monitor the skin temperature, heart rate, pulse oximetry, and HGT monitoring as required. So while transfer, also these things have to be monitored. The skin probe in place, pulse oximeter probe in place, heart rate to be monitored, of course, saturations, and HGT before transfer, and in case required during transport if the transport is going to take long. Babies are definitely going to lose heat during transport. So we are transferring the baby from one warmer to another transport incubator, then from the transport incubator to the NICU. So they are going to lose heat definitely. Pre-transport stabilization is the most vital step in the whole process of transport. So there's no point in carrying a 35 degrees Celsius baby to be shifted to the NICU. Let him become a little warm and then initiate the transport. Adequate and timely communication with the family, referral hospital, and the support group is also essential. So during transport, you can make a call, okay, the baby is 35 degrees only, or falling temperature, heart rate is unstable, or saturation is dropping, baby may need CPAP or oxygen or ventilator. Keep these things ready so that the adequate preparation is done at the receiving end also. The ideal transport system consists of these three important cogs. One is provision for mechanical ventilation, multiple fluid infusion therapy. So not only dextrose, at times a baby may require inotropes. So you should have 2-3 infusion pumps while transport, and good cardiorespiratory monitoring. It is not good to have a baby receiving a baby with bradycardia and poor saturations which were not picked up during transport. So transportation is very, very essential. In neonatology, when we started saving babies, we initially started keeping them in oxygen chambers. So a baby preterm was born and kept in a steel box with a lot of oxygen flowing there. Then we realized, okay, these babies are doing well. We started giving them 100% oxygen. Then with 100% oxygen, there was some effect on the health, morbidity increased. So we shifted to room air. With on room air, then babies started dying, the mortality increased. Then we realized no, oxygen was good. So we started giving higher oxygen and then getting them off oxygen early. So we have been trying to get to that balance between oxygen and room air. In the 1950s and 60s, the first epidemic of ROP was discovered. So what we were doing was we were giving oxygen to the babies, and we suddenly realized that babies are surviving but with retinopathy of prematurity. So we started restricting oxygen here, and then that led to increased mortality. So we then found out, no, we need to give measured oxygen, we need to screen and get rid of that ROP factor. So survival of LBW babies subsequent to 1980s and 1990s with use of surfactant and antenatal corticosteroids, it increased. So again we have the second epidemic of these morbidity factors like ROP, BPD and all. Now after this second epidemic, we are getting a third epidemic in the last 1 or 2 decades. That is because of increased survival of LBW babies where supplement oxygen is not checked. So we are giving oxygen liberally, we are salvaging babies, but we are also increasing their morbidity. This is the third epidemic, and it is mainly seen in moderately or poorly developed countries. So we are having newer ventilators, newer NICUs, we are using antenatal corticosteroids, the obstetricians are using that, we are using surfactant, it has become a little cheaper compared to the other pulses and all those things. So we are salvaging more babies but also giving them more morbidity. Over a period of time, we have discovered that the baby is not born with 100% oxygen saturation. The baby inside is hypoxic. At 1 minute, a term newborn will have a oxygen saturation of only 60 to 65%, which increases to 65 to 70 at 2 minutes, 70 to 75% at 3 minutes, 75 to 80 at 4 minutes, 80 to 85 at 5 minutes, and it reaches around 85 to 90% only at 10 minutes of life. This table is also provided in the resuscitation algorithm which we have given. So you can put it on the labor room. So what do we target? We don't target 100% saturation after delivery. Babies having acrocyanosis, when we attach the pulse ox, saturation is 88, 89, so give 100% free flow oxygen though. No. Every baby doesn't require oxygen, every baby doesn't require suction. So this is the oxygen saturations which we must be targeting depending on the baby's time of birth. Latest NRP recommendations also recommend use of ECG monitoring and pulse oximetry, mainly to have targeted oxygen saturation approach. So we need not make the baby red and pink and 100% on the monitor. In the 1960s, before the 1960s, newborn care was basically giving oxygen and fluid. In the 1960s, when mechanical ventilation came up, newer ventilators were developed, we started having adult ventilators used on newborns and separate newborn ventilators. 1970s CPAP was used on newborns. 1990s surfactant was discovered. Late 1990s and antenatal corticosteroids were used, and we were having good survival of newborns. However, all through these years, the most important factor which we noticed was a good functional residual capacity of the baby's lung. That is the most important thing. That is how the babies were surviving. We were ensuring that post-delivery a good functional residual capacity is achieved, and that helped the baby to breathe better and survive better. COIN trial, support trial, and a lot of other trials have studied this, and finally they came to the conclusion that a CPAP given to the baby immediately after birth will decrease BPD as well as risk of death, and is a good alternative to prophylactic or early surfactant. So early CPAP to the baby may actually prevent use of surfactant or decrease the use of surfactant in the newborn babies. This, how many of you have seen this device or used it? Very good. So at least a few of them are there. This is a T-piece resuscitator. It's not a very expensive device. 25,000 to 50,000 is the cost. This can be used to give delivery room CPAP. It can be used with blenders to give targeted oxygen therapy, and the oxygen can be titrated to meet the baby's saturation demands. It is useful in transport also. It's a very lightweight equipment. I think 1.52 kg is the weight. It is used to deliver PIP and PEEP. These are the single tubing connections. The PIP and the PEEP is delivered in a measured way to the baby. So rather than giving AMBU in case the baby is intubated and requiring resuscitation, rather than giving actually bag and mask ventilation, which we cannot control the pressures, this is a very useful method to give CPAP, and you can give just CPAP also by just setting the PEEP. So it can be used for delivery room CPAP as well as CPAP or ventilation during transport also. It's not a very expensive thing, so probably pediatricians and transport teams should start keeping this. This is a air oxygen blender. Now this also is a very inexpensive thing, somehow not able to get a foothold in our hospitals. This is a air oxygen blender. It can be used with a T-piece resuscitator, and it can be used to actually give measured oxygen to the baby during transport, post-delivery, in the labor room, during transport, and in the NICU also. It will help you decrease the risk of ROP, BPD, and periventricular leukomalacias. So Vermont-Oxford Networks study actually has seen that helping the baby with surfactant using the Ensure technique is very good. So there is no harm in starting CPAP in the delivery room, provided antenatal steroids and better perinatal monitoring has been done. And for babies who require intubation for RDS, Ensure may be the way to go. So what we do is we intubate the baby, give surfactant, extubate the baby, and then the baby goes on CPAP. So we are actually minimizing mechanical ventilation and the risk associated with mechanical ventilation on this baby. We are using CPAP. Whichever baby requires surfactant, Ensure technique is followed and the baby goes back on CPAP. So how do we manage oxygen and respiratory care in the delivery room? Place the pulse oximeter on the infant's right limb. This will give you a preductal saturation reading. Start the oxygen at 30% FiO2 and titrate it by 10% every minute to achieve the target saturation. So we have the list of target saturations in the labor room: 1 minute, 2 minute, 3 minute, 4 minute, 5 minute and 10 minute oxygen target. And then from 30% FiO2, 10% is 3. So after 1 minute, if the saturation is met, we decrease by 3. After another minute, if the saturation is met, we decrease by another 3. So saturation is now 24. After another minute, maybe we can decrease by 2. So now 22 and then 1. So we try to reach to the minimum saturation FiO2 possible to maintain the targeted oxygen saturation. The goal is to get a 70% saturation on the baby at 5 minutes of life, or 85 to 92% at 10 minutes of life. However, if there is prolonged bradycardia, heart rate is less than 100, then we need to give 100% oxygen. Sir Alan Jobe, senior neonatologist and professor, in his famous article, the article is called "Don't Just Do Something, Stand There." He has mentioned there is perhaps nothing more dangerous for the preterm lung than an anxious physician with an endotracheal tube and a bag. So intubation may not be the wise thing after all. What we learnt during our course, during our neonatology course, was how to avoid intubation, how to avoid ventilation. So maybe there are methods like early delivery room CPAP, antenatal corticosteroids, good delivery room care, maintaining good temperature, early CPAP, giving targeted oxygen therapy, which may actually help you avoid mechanical ventilation in the baby. After the transport, airway, breathing, circulation, we come to dextrose. And of course, it's lunchtime also, so we are also getting hypoglycemic. The baby tends to get more hypoglycemic. So we need to monitor the sugar levels of the baby and document the same. Often dextrose is forgotten. Often blood sugars are not done. We are more focused on oxygen and these things. If IV line is secured, the HGT is with the mother or in some other room. So there should be a machine in the labor room. Monitor the dextrose in case it is low, especially because of medico-legal things also. It is very important to document what sugar levels were noted, how you have rectified it, what measures have been taken to maintain euglycemia, and ensure that it is maintained during transport also. Especially in the sick newborns, dextrose or glucose is a nutritional emergency. So we should treat them as a nutritional emergency and start them on fluids as well as TPN as and when indicated. So there were a few case reports published in 2014. These were about 6 infants in 2013 which were admitted to Vanderbilt Children's Hospital, Nashville with life-threatening bleeding. Out of these, 4 had IVH, 2 had GI bleed. All of them survived, but 2 needed emergency neurosurgery. 1 baby had a stroke with a right-sided palsy and severe cognitive delays, and 2 had mild to moderate brain injuries. Now, amongst these 6 babies, their age was commonly between 7 weeks to 5 months. 3 of them were males, 3 females. 3 were born in the hospital, 2 at home, and 1 was delivered at a birth center. All were vaginal deliveries. No sections, no instrumentation was done. No antibiotics were given to the mother. All these babies were exclusively breastfed. So what did these infants have in common? Any guesses? None of these babies had received vitamin K shots at birth. For various reasons, some were born at home, so they were not given. Some parents delivered in hospital, but they refused, saying no pricks to the baby at such an early age. So even in Western countries, these things happen. So we come to vitamin K, K for coagulations. So this is a vitamin which promotes coagulation, and deficiency of this vitamin can lead to vitamin K deficiency related bleeding, in which coagulation is corrected rapidly by administration of vitamin K supplementation. Typically INR is almost around 4, or prothrombin time may be elevated to 4 times the control value. So these recommendations have been in place since 3 decades almost now. American Academy of Pediatrics recommend vitamin K to be given to all neonates as a single IM dose of 0.5 to 1 mg depending on the maturity and the weight. Similarly, Canadian Pediatric Society has also given their recommendation, and University of Missouri also had a huge number of reviews. 23,200 infants were reviewed between almost for 30 years, in which there was no classical case of HDN detected in the babies who were given prophylactic vitamin K. So we have the recommendations AP with the 1961 recommendations, and they have reconfirmed it in 2003 and 2009 that a single dose of vitamin K to be given at birth. Canadian Pediatric Society has their own set. This is what we are commonly following. And Italian Society, UK Department of Health have also given their recommendations. What we use commonly is the vitamin K1, the phytominidone, which is safer, which is available as a single dose of 0.5 ml. 0.5 ml contains 1 milligram. So that is safer to use and more effective. So this is the vitamin K which we can store. There is benefit of using this in terms of decreasing the error also is there, because it's available as a single dose. Otherwise we have a 1 ml vial from which we take 0.2 ml to be used as IM, which is quite often mistakenly given. Methergin is given in place of vitamin K. We have noted 2 cases in the last 16 years, and when we did a study there was a huge number of such case reports. So instead of vitamin K, methergin is loaded. The obstetrician is asking for methergin, pediatrician is asking for vitamin K. There is only one staff, so she loads 0.2 ml of methergin and that is given to the baby IM. So just be cautious about this error. The baby, the effects of this is apnea, bradycardia, and the baby had actually required CPAP support in one of the cases. What other red flag signs should we rule out in the first hour of birth or immediately post delivery? Rule out tracheoesophageal fistula. This is an emergency which requires different management and will require surgical intervention. Rule out imperforate anus. There is no way that these things should be missed out. Choanal atresia to be ruled out. Congenital diaphragmatic hernia, of course, if it is antenatally detected, it is really good. Avoid bag and mask ventilation. In case of congenital diaphragmatic hernia, these babies will require selective intubation. And of course, in case of meconium stained Licher amni, we will be using the meconium algorithm, which is given in the IAP algorithm within the folder. So the key messages which we need to take home today is: first, keep calm, don't panic. Whatever you can do, whatever you are capable of doing, whatever is available with you, you will be able to put to better use if we are calm. Anticipate a difficult delivery and have the skilled delivery room care ready. So we need to have skilled people, skilled equipment ready for each and every delivery. Give a warm welcome to the newborn. Manage the airway, breathing, circulation, and dextrose. Don't forget dextrose. In case the baby is sick, requiring transport, safe, effective transport to be provided. In case ELBW or babies less than 30 weeks, we can use the plastic bags or the plastic wraps for transporting the baby. Give measured oxygen to the baby. Use of blenders is very effective, and T-piece resuscitator, not to forget. I think 2 things we can buy immediately is T-piece resuscitator and blenders. Early CPAP, delivery room CPAP, and actually will ensure better outcomes for the baby. And don't forget to give vitamin K. Of course, rule out life-threatening anomalies once the baby is stable or earlier if possible. At the end, there is a line by Gabriel Mistral written in 1948. We are guilty of many errors and many faults, but our worst crime is abandoning the newborn, neglecting the foundation of life. Many of the things we need can wait. The child cannot. Right now is the time. His bones are being formed, his blood is being made, and senses are being developed. To him we cannot answer tomorrow. His name is today. So give this crucial 1 hour to the newborn for a better future. Thank you.
Thank you, Dr. Dixit. That was really great. You just summed up first Golden Hour very nicely. Any questions from the audience?
I wanted to ask you about the TP's resuscitator. I really haven't seen it much. But is there a pressure gauge? I could see a pressure gauge on it. So and how many ml per minute? I mean, oxygen. 30% you said this, but how many ml and what is the pressure gauge readings?
So TP's resuscitator commonly we have seen available is with two companies. This is a Fisher-Paykel Neopuff. It is called Neopuff. And there is another company called Phoenix that is costing 25,000. This is around 50,000. Now, there is a oxygen port behind which needs to be connected to a oxygen outlet or to a oxygen and air blended outlet. So we can use a blender also, which will have a common connector coming to this. The pressure, the flow is usually kept around 10 to 12 liters. And then we need to set the PIP. We have a knob here, this knob, which will help to set the inspiratory pressure, desired inspiratory pressure. The inspiratory pressure is visible here. So once the oxygen flow is generated, we connect these tubings. This tubing will come here. This tubing will go to the oxygen source or to the air oxygen blended source. This tubing, this end will come here. This end is to be connected to the universal endotracheal tube, the universal ET connector. So this end. Now there is a white circle here which is the regulator for the PEEP, for the end expiratory pressure. So the PIP is set from here, PEEP is set from here. So PIP we set from here, we close this end, the ET end of the tube, close it with our palm, close the PIP with our palm, and then you will see the pressure, the positive pressure generated. Once there is a hole here, once you release the thumb pressure, that will give you the PEEP. So in case the ET is there and this tube is connected, the continuous CPAP will be delivered to the baby. So depending on the baby's condition, we can set PIP from say 15 to 25 as per the requirement, and PEEP is set usually at 5 or 6. So this will give a continuous uniform PIP as well as PEEP. PIP and PEEP in case we need to, like baby is ventilated and in case we are giving intermittent positive pressure, then we need to just use our thumb to give measured PIP. So say we are setting a PIP of 20, so 20, 20, PEEP of 6, 20, PEEP of 6. Rather than giving, if you are more excited, the PIP goes up to 30. There is baby is having bradycardia, you are bagging too fast, rate is fast. So we just do breathe, 1, 2, breathe, 1, 2, breathe, 1, 2. So the rate as well as the pressures are measured and regulated. So it will prevent lung injury also, and in case baby is requiring CPAP, just connect it and keep. It will deliver continuous CPAP to the baby. Very easy to use, the staff can use it. In fact, most of our staff use it themselves.
But you need to intubate the baby, sir?
This can be used in two ways. One is the intubation way. Second is we can use it with the mask. Or the third thing is which we use is in case the baby is requiring CPAP, we give the nasopharyngeal airway. So the ET is cut at around 7-8 centimeters. The connector is reconnected. Then the ET is inserted into the nasopharynx. So it goes into the nasopharynx and then it is fixed and connected to this resuscitator. So this will provide good CPAP to the baby.